We've got a clinical case, my beloveds. 60-year-old lady presents with chest tightness on exertion. Her resting ECG is normal and troponin levels are within normal range. Okay. She has hypertension and mild hyperlipidemia. Okay. Her doctor suspects stable angina and wants to confirm or exclude coronary artery disease. Actually, good idea. Which of the following is the most appropriate next step in her diagnostic evaluation? Interesting. Give me the options. Echocardiography. Exercise treadmill test. Yes, actually 60-year-old lady. Why not? Computer tomography, coronary angiography. Maybe this one. Invasive coronary angiography. Actually, I don't know. I'm between exercise treadmill test, it's a classic, and computer tomography, coronary angiography. No, let it be computer tomography, coronary angiography, but I'm for exercise treadmill test actually. A correct option is coronary angiography. Now, what is the logic, my beloveds? Coronary CTCA, computer tomography, coronary angiography, is recommended as the first-line diagnostic test for patients with stable chest pain and intermediate risk of coronary artery disease. Why? It's not invasive, highly sensitive, and can visualize both coronary lumen and plaque burden. Invasive angiography is reserved for patients with positive or inconclusive non-invasive imaging or high clinical suspicion. But, okay, actually good question. Let's go into details. Let's go through each option step by step and explain why other options are incorrect. So let's recap the scenario. What we've got? We've got 60-year-old lady, right, has exertional chest tightness. Highly likely it might be it's a coronary artery disease. But normal ECG and normal troponins. This means she has stable angina, right? Not an acute coronary syndrome at all. So the question is about the next diagnostic step to assess for coronary artery disease. Now about echocardiography. No, it's incorrect actually. If it's a just echocardiography, it's a not stress echocardiography. A resting echocardiogram is useful to assess heart structure and function. Okay, for example, left ventricle ejection fraction, wall motion abnormalities, it's most important in this case, or valvular disease. However, in stable angina, a resting echo doesn't show coronary artery patency or plaque burden. A resting echo, I repeat, unless there is a suspicion of heart failure or structural abnormalities, it doesn't help diagnose coronary artery disease directly. Use echocardiography if you suspect, I don't know what, valvular heart disease, no 60 years old lady, actually no history of arterial hypertension, cardiomyopathy, or to assess cardiac function after myocardial infarction. But we do not have a history of myocardial infarction and no history of arterial hypertension, no history of rheumatic heart disease concerning valvular problems. So it's not the first line test for suspected stable coronary artery disease in our case. Next, exercise stress test, treadmill. Actually, my opinion is correct, not partially correct, but little bit outdated and less accurate. Why? Treadmill stress test, historically used for evaluating exertional chest pain. It has limited sensitivity and specificity. Specificity around 70% for coronary artery disease, but only in the cases if we obtain some maximal heart rate. If we obtain maximal correct stress test, it's 100%. No, around like 100%. It's only Jesus Christ, but it's more than 90%. Why not? We can use this technique in this case, but unfortunately now, I don't know why, we do not have very good specialists of treadmill tests worldwide, these last 20, 30 years, we lose this ability. We lose this art of diagnosing of coronary artery disease using stress test. I adore stress test. So many patients, we have to say also that many patients, especially women, elderly or those unable to exercise adequately, get false positive or false negatives. Actually, false positives without real ST segment changes means ST densa, depression or elevation. But 60 years old lady can walk. What is the problem? 60 is to not 80 or 90. And plus, modern guidelines such as NICE and ES, European Society of Cardiology, recommended computed tomography coronary angiography instead of exercise treadmill test as the first-line test for new onset stable chest pain. But, after treadmill test, my opinion. So finally, stress test may be useful for assessing exercise capacity or prognosis, but not for initial anatomical diagnosis. Maybe. Actually, I understand that correct answer is a CT computer tomography angiography, but my good advice, first, stress test, then, why not, do your computer tomography, coronary angiography. Yes, concerning invasive coronary angiography, incorrect. Too early. This is the gold standard for coronary anatomy, but it's invasive. Involves catheterization, contrast risk, and radiation, of course. Not the same risks concerning contrast and radiation. And it should be preserved for patients with positive CTCA, i.e. significant stenosis, high-risk symptoms or unstable angina, high-risk, positive treadmill test, positive stress test results requiring confirmation, of course, classic. Anyway, invasive coronary angiography is not the first diagnostic test in stable angina with normal ECG and troponin, by the way. And so finally, our correct option is a coronary angiography. It's a correct option, non-invasive, fast, provides detailed visualization of coronary anatomy, detects both obstructive and non-obstructive plaques, excellent negative predictive value. If CTCA is normal, CTS is normal, coronary artery disease, highly unlikely. Very, very unlikely. And recommended as first-line imaging in stable chest pain with intermediate pretest probability by NICE, the CG95. It's actually 2021 update. NICE update, and European Society of Cardiology updates, 2099, if my memory doesn't fail me. So, correct option, coronary angiography, but I am for stress test. Stay blessed, my beloveds.